Thanks very much for coming to the Kirby seminar today, which is going to be given by the student prize winner for this year. I'd like to start by acknowledging the traditional owners of the land on which we meet. And here in this room, we're meeting on the lands of the Bidjigal people, and pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islanders who are joining us today. So today, as I said, the lecture is being given by the student prize winner. This is an annual event, and it's awarded to the person that is first author on the paper judged to be most significant published in the previous calendar year. I think it's really important at the Kirby that we acknowledge the efforts of our students. They're a very significant part of the Kirby in terms of numbers, but even more importantly, in terms of the way the place works, the way the place functions, and the culture of the place. And so this is an acknowledgement of student achievements, I think, is very important. And this is one way we do this, and something that we hope to continue. So this year's award winner is Yumi Sheehan. And Yumi has been here since 2018. And she is both a research project manager as well as a PhD student in the VIS program. And her research is focused on improving health outcomes for people with hepatitis C in prison, including interventions around models of care, particularly around the implementation of point-of-care testing, education, and surveillance. And she submitted her PhD in September this year, so she should be very relaxed. Yumi is involved in a range of national and international prison-based hepatitis C research, and is through leading the implementation of VISP's prison-based research studies, as well as being on the executive committee of the Australian National Prisons Hepatitis Network, and also the executive committee of INSU. The paper for which Yumi received her award is called "A One-Stop Shop: Point-of-Care Hepatitis C RNA Testing Intervention to Enhance Treatment Uptake in a Reception Prison, the PIVOT study." And this was published in the Journal of Hepatology. And the papers, Yumi will obviously present the findings of that paper, but it provides important insights for policymakers regarding the optimal HCV testing and treatment pathways for people who are newly arriving in prison. We will have time for questions at the end. And so if you're online, please add those to the Q&A icon, and in the room, if you could come to the microphone so that the people online can hear your questions. Yumi?
Thank you so much, Tony, for that introduction, and also for the opportunity to present today. I would also like to start by acknowledging the traditional owners of the land on which we're meeting today and which we're presenting, the Bidjigal people of the Eora Nation, and pay my respects to elders past, present, and emerging. I also really want to thank the committee for selecting this paper as the 2020-24 student prize winner. I'm really excited today to present on the primary paper from the PIVOT study. And this paper was a chapter in my PhD thesis. And as Tony mentioned, I just submitted a couple of months ago, which is really exciting, in September. I have no personal disclosures. So I just want to start out by with just some acknowledgements, and especially Andrew Lloyd, who was my primary supervisor, and Jason Grebley, who has been a mentor throughout my PhD journey, and both of them were the senior authors, co-senior authors on this paper. I also want to acknowledge my co-supervisors, Lise Lafferty and Nico Tedler, who really also got me through this thesis, and in particular this chapter. And also Amanda Cochran, who is the PIVOT study nurse, who really conducted the study on the ground. So I couldn't have done this paper in particular without these people. as well as all of the participants and the collaborators who were involved in the study. And in particular, I want to acknowledge all of the people in prison who are up at Mid-North Coast Correctional Centre who generously provided their time or gave their time to participate in this study. We also have really strong collaborative relationships between the Kirby Institute and Justice Health New South Wales and the Corrective Services New South Wales. And without this really strong relationship, we wouldn't be able to do a lot of the work in the prisons in New South Wales. We also, our funders, just straight up, our funders, AbbVie, NHMRC, and Cepheid for making this work possible, and also the entire Pivot team. So beyond just my supervisors and mentors, we had the whole Pivot study team, it also included Marianne, Greg, Lise, Evan, Tracy, Colette, and Tom. Okay, so just a bit of high-level background for you. So hepatitis C is a global public health concern, with current estimates placing over 50 million people living with hepatitis C globally. And a large majority of these people are people who inject drugs. And in 2015, we had highly effective, tolerable, and curative direct-acting antiviral treatments, or DAAs, which were developed, and this revolutionized the landscape for hepatitis C treatment. So against this backdrop, the World Health Organization set ambitious targets to eliminate hepatitis C as a public health threat by 2030, and this includes targets to reduce new infections of hepatitis C by 90%, ensure that 90% of those living with hepatitis C are diagnosed, and 80% of those diagnosed are treated. And Australia has committed to reaching these targets by 2030, and we've got the 6th edition of the National Hepatitis C Elimination Strategy just about to be released. So Australia initially made good progress towards elimination of hepatitis C, and we were on track to achieve the WHO targets to eliminate hep C as a public health threat by 2030. A huge facilitator of this was the listing of the highly effective DAAs on the Pharmaceutical Benefits Scheme, or the PBS, and availability of the therapies to all Australians, including people incarcerated in prisons. And since their listing on the PBS in 2016, we've done really well at identifying and treating a high number of individuals. And you can see this here on the graph on your left, that there was an initial surge in treatments in 2016, but you can see also that the treatment initiations are on a downward trend, and modeling studies indicate that we're actually no longer on track to achieving elimination by 2030. So to try and get back on track, we need to continue to actively case find and test and treat all those with hepatitis C, in particular amongst high-risk populations such as people who inject drugs. And because of the high rates of drug-related incarcerations, there are also high rates of people who are injecting drug use in the Australian prisons. And there's also a high chronic hepatitis C prevalence in Australian prisons. And nationally, this is around 8%. This unfortunately makes prisons somewhat of an opportune venue for testing and treatment efforts. And in Australia, they've been considered a priority setting in the National Elimination Strategy. So just taking a closer look, we're looking at the same screen, aren't we? Just taking a closer look at the national total treatment initiations from 2016 to 2022. So that's the pie graphs on the right. Of all of the treatment initiations that happened nationally in 2016, 6% happened in the prisons. And by 2022, this proportion had increased to over a third of all of the national total. So that means that over a third of all treatments that were happening in Australia were happening in the prisons in 2022. But this still represents only a small portion of people with hepatitis C in prison who are eligible for treatment, actually initiating treatment in the prison. And so lots of people remain untreated in the setting. And as you can see, there is a growing importance for prisons in national elimination, giving that growing contribution to national totals, but further strategies are needed to continue to engage individuals with testing and treatment in the setting. Okay, setting the scene a little bit about the Australian prison setting. So prisons are unique physical structure, and they generally have a lot of overcrowding. They're complex and challenging environments that's kind of physically, socially, and psychologically. Prisons have an overrepresentation of minority and marginalised populations, such as those from poorer socioeconomic strata, foreign nationals, Aboriginal and Torres Strait Islander people, and people who inject drugs. And many of these people are populations with complex health needs. The Mandela rules stipulate that an equivalence of care principle should be in place, that people in prison should enjoy the same standard of care, healthcare, as is available in the community. But despite this mandate, both globally and in Australia, healthcare services in prisons remain suboptimal. And compared to those in the community. And there are logistical, organizational, societal challenges to implementing healthcare in the prison sector, and this hinders adequate access to care. Prisons are settings, as I mentioned, with high hepatitis prevalence, but also incidence with ongoing injection drug use and sharing of both limited and unsterile injecting equipment as key risk factors. So in Australia, we have around 110 adult correctional centres across the country. There is a lot of movement in the prison setting, with lots of people coming in and out of the prison setting or transferring between the different prisons. Most people are generally only in prison for a short period of time. The high prevalence and frequent movements of the people in prison, coupled with some limited nursing capacity and competing priorities both between health and corrections, mean that there are challenges to people in prison efficiently completing the hepatitis C care cascade and making their way actually onto treatment in the setting. And then reception prisons, they're prisons that take those who are just coming into prison from the community. They generally have a high turnover and high throughput, ranging from around 20 new receptions per week, all the way up to 20 per day. And so the prison reception period provides an opportunity to engage a high number of people with healthcare, just as they're coming into the prison system, and in particular presents an opportunity for a high risk and largely underserved population to engage with efficient hepatitis C testing and treatment. So this here is just an example of a typical pathway that someone takes when they come into prison. And so it's important to note that there are some variation across the different jurisdictions in Australia, but this is a fairly typical pathway. So I'm going to walk you through this pathway a little bit. So the pathway generally involves consultations with several different healthcare providers. So that might be nurses, GPs, specialists, and in general, it can take a long time, several weeks, often months, for people to actually move through the pathway to treatment initiation. So firstly, they'll have a reception interview within 48 hours of incarceration, and this is largely an opportunity to screen for suicide risk, drug withdrawal, other high-risk conditions. And in the context of bloodborne viruses, this is where nurses provide referrals for the bloodborne virus or STI screening for those who are deemed at heightened risk. And so by that, we mean people who use drugs or people who inject drugs. But reception is generally a highly stressful and highly turbulent time for prisoners. So you just need to be a bit sensitive around this time frame. Next, at a separate time point, people may then go on to have bloodborne virus or STI screening. This is where hepatitis C antibody pathology is taken. If antibody positive, they then may go on to have a further clinical assessment and then pathology for hep C RNA, again at a separate time point and likely with a different nurse. And then following on from that, they may have some other clinical assessments and then a specialist consultation for treatment suitability with a view to DAA prescription and thence treatment initiation. So all of those, again, may happen at separate time points and in separate visits. So this relatively complex multi-step care cascade, as you can imagine, imposes multiple challenges for people, to be retained in the care cascade and multiple opportunities to drop off the care cascade essentially at any time point throughout this journey. So care cascades with fewer steps offer an opportunity to better retain individuals in care and are especially critical for the prison sector. So the advent of Cepheid's expert hepatitis C viral lobe finger stick assay, which you can see up here, potentially provides a great opportunity for improved efficiencies in the hepatitis care cascade in various settings, but in particular for reception prisons where there is a high pre-test probability given the high prevalence, as well as a high throughput of people. So with the point of care test, a blood sample is collected from a finger prick and it's deposited into the cartridge. This cartridge is then placed into an expert machine. You can run several tests at once if it's a multiple cartridge machine, and the assay provides a quantifiable hepatitis C RNA result in 60 minutes. So this opens up the opportunity for a single visit diagnosis, and it brings us just one step closer to a single visit test and treat. The assay has very high sensitivity and specificity, and it's comparable with traditional lab tests. There are just a small number of requirements for the point of care testing, but generally all that's needed is the laptop that comes with the machine, some regular consumables and disposables, and a workplace or a workspace with a sharp spin. So when we first commenced the PIVOT study in 2019, there were no studies evaluating point of care testing interventions in the prison settings. But then once we got started with the study, a couple are published while we were actually conducting the study. So Giuliani et al. Conducted a study in 2 Italian prisons which evaluated a test and treat model of care. This involved universal opt-out testing strategy on reception using both standard venipuncture tests and a rapid point of care test for antibodies. That was to screen for hepatitis C antibodies, and they did that using saliva samples as well as an additional venipuncture sample. They also had pre-test counseling by a specialist physician, linkage to on-site specialist care, both patient and staff education, and then a fast-track treatment DAA initiation. So the study reported a high antibody and RNA testing coverage of both 89 and 99% respectively, which is really great, but there was only a moderate treatment uptake, around 42 to 54% of those eligible, and really lengthy times to treatment initiation, with people initiating in a median of 4 months. This was largely due to the milestones, so the care cascade being conducted over several separate visits and a need for the venipuncture sampling in addition to that point of care testing sampling, and the venipuncture required offsite processing. And then there was also Mohammed et al. In 2020 who evaluated a rapid point of care testing model. And this was, again, kind of antibody testing with reflex to RNA testing using a point of care test and then the expert viral load test. This was coupled with a fast-track clinical assessment, pan-genotypic DAA prescription, and treatment initiation. So this was a little bit more of a streamlined pathway than the Italian study. This study was shown, or this model was shown to be superior to a standard of care, which in the London prisons was DBS testing. And this was conducted in one large remand prison in West London. So the point of care testing approach, again, resulted in a high testing uptake, 90% versus 47% in the standard of care, and treatment uptake, so 85% versus 21% compared with the standard of care approach. But the point of this model of care was still somewhat constrained in efficiency because you still did need to have the venipuncture rather than just purely finger prick sampling. And again, offsite processing for that sample was still required. The clinical assessment and the treatment initiation, again, was scheduled across several separate visits in the care cascade. And so they were conducted over 3 separate visits, all happening on different days. But you can see here that these studies really demonstrated that point of care hep C testing in prisons was feasible, but opportunities for further simplification and streamlining of that care cascade was evident. And so that is exactly what the pivot study had aimed to do. So we aimed to streamline the care cascade even further by combining all of the key assessments into a single one-stop shop visit. So the primary objective of the pivot study was to evaluate a one-stop shop intervention that integrated point-of-care hepatitis C RNA testing, a FibroScan, clinical assessment, and fast-track DAA prescription on treatment uptake among people newly incarcerated in prison. The primary endpoint for this study was treatment initiation at 12 weeks from enrollment, and a couple of the key secondary objectives that I'll talk through today were to compare the proportion of people tested for hep C prior to and following the intervention, as well as to compare the time taken from enrollment to each of those steps in the care cascade through to treatment initiation. So the pivot study was conducted, as I mentioned, up at Mid-North Coast Correctional Centre, which is a reception prison up on the Mid-North Coast in New South Wales, up in Kempsey. All newly incarcerated adult males, so that was those people who had been incarcerated within the previous 6 weeks and who had no prior DAA treatment were eligible for inclusion. Those with hepatitis B co-infection, an invalid FibroScan result, or who had evidence of cirrhosis were excluded from initiating treatment through the study, and we referred those people for treatment through the standard of care. So the pivot study was a prospective, non-concurrent controlled study with both a control and an intervention phase. So in the control phase, which is here on your left, participants were enrolled from October 2019 to May 2020. And those people who were enrolled underwent a nurse-led interview-style survey. Then they were just observed as they made their way through the standard of care for testing and treatment. And the number of patients who were initiated on treatment through the standard of care were reported. Then in the intervention phase, which you can see here on your right, we enrolled people from June 2020 to April 2021. And participants in this phase were enrolled, and then they underwent that one-stop shop point of care testing and intervention. Those who were hep C RNA positive were initiated on treatment through the study, and then they were followed up at end of treatment and at SVR12, both with a hep C RNA point of care test using that expert test to determine cure. And again, the number of patients who were initiated on treatment through the intervention were reported. So taking a little closer look at the one-stop shop point of care intervention. So the one-stop shop, as I was saying, combines all of the key assessments for hepatitis C into a single nurse-led visit. So participants in the one-stop shop had a point of care hepatitis C RNA test using that expert finger prick assay. They also had a hepatitis B surface antigen point of care test. They had a FibroScan for non-invasive liver disease assessment. They had a clinical assessment and a nurse-led interview style survey, all that happened within the same 60-minute visit. Those who were RNA positive from the point of care test then had a fast practice prescription for pangenotypic DAAs from a specialist, which usually happened via telehealth and usually happened the same day. And then fast tracker treatment initiation, so to facilitate that fast track treatment initiation, this happens generally within a couple to a few days. And we did have an arrangement with the Central Justice Health Pharmacy, which happened to be in Sydney rather than Kempsey. So we had a priority dispensing agreement, which was really great, but it did take some time for the medications to actually move from Sydney all the way up to Kempsey on the mid-north coast. So in terms of participant characteristics, so the characteristics including age, Aboriginal and Torres Strait Islander status, previous incarceration, history of injecting drug use, and recent injecting drug use were all comparable amongst the participants in both of the phases, so both the control and the intervention phases, as you can see up here. Okay, so now for some results. So this will be I'll be showing you throughput in testing and treatment in the standard of care versus in the one-stop shop intervention. And it is important to note that the study was conducted at a prison that's actually considered to have pretty good health services. So one that has reasonably good hepatitis service delivery in the standard of care. So just keep this in mind. So the first 239 people who were enrolled in the study, and enrollment happened shortly after reception to prison, they were observed as they made their way along the standard of care pathway. So among the 239 who were enrolled, 115 or 48% had reported ever injecting, 63 or 26% underwent testing for hep C antibody or RNA testing, among whom 18 or 29% were found to be RNA positive. 4 or 22% were initiated on treatment, and then there were no cures that were reported as part of this standard of care. And it generally took a median of 99 days for people to initiate treatment through the standard of care. So then in the one-stop shop intervention, among the 301 people that were enrolled, 124 or 42% reported ever injecting drugs or a history of injecting drugs. 298 or 99% underwent point of care testing for hepatitis C RNA, among whom 30 or 10% were RNA positive. 28 out of those 30 or 93% were initiated on treatment. 15 or 50% had a treatment completion reported or recorded, and 11 or 39% had an SVR or a cure recorded as well. And in the intervention, it took people a median of 6 days to initiate treatment. So as you can see here, there is a dramatic increase in both testing uptake from 26% to 99% and in treatment uptake from 23% to 93% in the one-stop shop intervention versus the standard of care. And the time to treatment initiation was also markedly reduced from 99, a median of 99 days to 6 days in the one-stop shop intervention compared with the standard of care. So we also conducted a qualitative sub-study to the PIVOT study to understand the acceptability and the barriers and facilitators to point of care testing in the prisons. This work was led by Lise Lafferty, and this was the subject of 2 separate qualitative papers. And so although these papers weren't part of the primary paper and these results weren't part of the primary paper that I'm presenting today, I did want to include a quote which I thought really well attested to the one-stop shop. So this was kind of fell under the category or the component of point of care screening really is able to curtail some of the systemic barriers. And so this participant, Brendan, who had a history of injecting drug use, said, I knew of my hep C 9 years ago. And because I've been in and out a few years, just to say, for instance, I got tested here. Now I got sent from here down to another prison, and then they've lost my paperwork. So they do all the blood tests again. And then it's 3 or 4 work weeks before they get a result back. In the meantime, I've been moved again. And so then we ended up getting the results. And now it shows that, yes, I do have hep C. And then I come back and say, well, we can't start treatment because we don't have the genotype. Now, this has been ongoing for the last 6 years. And I'm glad that this time when I come in, I got tested in the first week I was here. Within the hour, yes, I did have Hep C. And not even a week later, I started the medication. So I feel like this quote really nicely encapsulates one of the participants' experiences with the one-stop shop. So the one-stop shop intervention that incorporated that point of care testing, the FibroScan, nurse-led clinical assessment, and the fast-track DAA prescription within a single visit was associated with increased Hep C testing and treatment compared with the standard of care. This intervention improved efficiency of the care cascade by markedly reducing the time to treatment initiation. But rather than any single standalone element, it was the combined package of the one-stop shop elements that was the likely contributor to facilitating that enhanced treatment uptake. And unbundling the key elements will likely lead to delays unless all of those assessments happen actually on site and probably on the same day. Another likely facilitator to the high treatment uptake in this study was we did have funding for a dedicated research nurse and a correctional officer, and we also had dedicated clinic space for the study at the prison, which is quite rare. So we did have it was well-resourced to be able to facilitate this high treatment uptake. But importantly, integration of point of care testing, it was also able to overcome the extended time to the provision of laboratory testing, which was generally several weeks because of that requirement for offsite processing. And it also overcame the poor venous access by using a finger prick test, because poor venous access is really common among people who inject drugs. So now, because this paper was this award is really to do with the impact and the significance of this paper, I'm going to spend a little bit of time on that impact. So this research was the first controlled trial to evaluate the impact of a one-stop shop Hep C point of care testing intervention on testing and treatment uptake in prisons globally. The findings have provided policymakers with important insights regarding optimal Hep C testing and treatment pathways for people newly incarcerated in prisons. They've also contributed to improved health outcomes for people in prison who have chronic hepatitis C infection, because it's increasing testing and treatment, thereby reducing infections, liver-related morbidity and mortality, and also the comorbidities. I've been fortunate enough to present this paper and these findings at key seminars and scientific conferences, both nationally and internationally. And the study is currently touted as the strongest evidence base for streamlined models of care in prisons globally. So as Tony mentioned, this paper was published in the Journal of Hepatology, which has an impact factor of 26.8. The paper has a field-weighted citation index of 2.9. It's been cited 20 times since its publication in academic publications, and it's also been cited 3 times in best practice guidelines. So evidence from the PIVOT study, as I mentioned, they've been cited in best practice guidelines. One of them is the National Prisons Hepatitis Network consensus statement on the management of Hep C in Australia's prisons, and the INSHU Prisons Global Guidelines for Viral Hepatitis Service Delivery in Prisons. And so the evidence underpinned the four best practice recommendations in both these national and international guidelines, and this encompasses universal opt-out Hep C testing, which should be adopted upon entry for all newly incarcerated people. Testing for Hep C should ensure a rapid turnaround time, such as with point of care testing. Universal access to DAAs should be available to all people in prison with hepatitis C infection, and this should be in alignment with the community standards and international guidelines. And fourth, evaluation of DAA treatment initiation should be done in the shortest time possible. And in Australia, these clinical practice guidelines are already being used to benchmark hepatitis service delivery in the prisons. And on the global side, we anticipate that global uptake of these guidelines are imminent. They've just been launched in October this year. The research was also cited in INSHU's international consensus recommendations for overcoming barriers to implementation and expanding global access to point-of-care testing for hepatitis C. The study also provided the prisons data set, which demonstrated the benefits of point-of-care Hep C testing, and this was critical in securing over $35 million in cash and in-kind support, and that included long-term funding from the Commonwealth Department of Health for the development and the delivery of the National Hepatitis C point-of-care testing program, which is being led by Jason Grebley and his team. The program, so this national program, aims to scale up point of care testing to over 100 sites nationally, including prisons. And it also establishes collaborations with over 150 stakeholders nationally, and that's from governments, prison health services, corrections organizations, consumers, researchers, providers, and industry. On the basis of the study's results, point of care Hep C testing is now being implemented in prisons in all Australian states and territories, with the exception of Northern Territory because they have such a low Hep C prevalence. And streamlined pathways to hepatitis C treatment are being prioritised in the prisons as well. In the prisons in June this year, over 12,000 point of care tests were conducted through the study. Over 1,700 individuals were diagnosed through the study, through the program, and over 1,280 were treated for hepatitis C through the program. And these numbers have only increased further since June. So this national point of care program is really supporting the scale up of point of care testing in prisons across the country. The Pivot Studies one-stop shop model was also showcased globally as a successful model of care for the prisons, and this won an award, a Global Connecting with Care Global Award. And this is just some snippets of the infographic that has been disseminated globally. Just in terms of limitations from the study, so some other things to be considerate of. So this study was conducted as a single prison site in Australia, where we do have universal healthcare and we do have DA treatment accessible to all people in prison. The study also enrolled only newly incarcerated males, and so the applicability of these findings to females and to other prison settings nationally and internationally at the time of when we published was unknown. It would have been preferable also to randomize participants to either the standard of care or the one-stop shop intervention, but it was just not really considered feasible or acceptable to do this in the prison setting. A large proportion of participants, as you saw from those outcome data, were released to the community at various stages throughout that care cascade, and so there were some gaps in the outcome data. This is not uncommon in prison-based interventional studies. The study also had a small sample size, in particular among people with current Hep C and people initiating treatment, and so caution should also be taken in interpretation of the findings. But in saying that, since the completion of this research, the findings regarding the major facilitators to streamlining of the pathways have been corroborated by several subsequent studies that have been conducted both in prisons and in community settings, both in Australia and in other countries, and you can see them listed up here. And point of care testing and streamlined pathways of cares have also recently been recommended in updated WHO guidelines, and in the WHO guidelines, people in prison and prison settings are remaining priorities. Qualitative exploration of the role of point of care testing, as I mentioned earlier, they revealed that people in prison consider point of care testing as part of a one-stop shop to be both acceptable and a facilitator to engagement in Hep C services in the prisons. And finally, a cost-effectiveness study found that point of care testing is more effective than laboratory-based standard of care for populations who are at risk for Hep C. Testing strategies that combine point of care Hep C antibody and RNA testing are the most cost-effective strategies in most settings, including in the prisons. So in combination, all of these data indicate the proactive simplification of Hep C care in complex and often resource-poor settings, such as prisons, improves testing and treatment outcomes and really should be implemented where possible. So now thinking beyond the prisons, the Pivot study, some of the bigger picture considerations that I just wanted to kind of talk through a little bit. So there are some further considerations that we can think about for more successful and widespread scale up of Hep C point of care testing in the prisons. So for example, just thinking about the Pivot study and how we can further this, there is potential for each element of that one-stop shop model of care to be simplified even further. And this can allow for even further streamlining of the care cascade. So for example, the Hep C RNA finger prick test could potentially be replaced by a two-tiered point of care screening process, which involves point of care antibody followed by RNA testing. And that RNA testing could happen potentially only among those with an antibody positive result or known prior Hep C infection. This approach has been shown to be cost-effective, as I mentioned just before. The screening for active Hep B infection could also potentially be triaged to only those with diagnosed with Hep C infection, given this test is really primarily relevant for treatment initiation. Age-based triage for fibrosis assessment could be removed for most patients under 35 years of age, and this could be in line with current best practice recommendations. Instead of a nurse-led model of care, it could be a nurse prescriber-led model of care, which would allow for on-the-spot prescription and earlier treatment initiation. Shorter treatment courses, potentially such as 4-week therapies, which are currently in clinical trials, could facilitate higher rates of treatment completion. Assessment of cure at 12 weeks post treatment completion, or SVR12, could be replaced with SVR4 to allow for an earlier determination of cure at 4 weeks post treatment completion. But I guess we need further research to understand whether the implementations of such a heavily simplified model of care in the prison setting will work. Another consideration here is for, I guess, with point of care hep C testing, whether it's antibody or RNA testing, is that it simplifies testing for hepatitis C in isolation from other prevalent infectious diseases in the prisons. So this could be hep B, HIV, syphilis, and these are all tests which are routinely screened for at the same time, and usually done on a single venous sample, and usually done on prison reception. So this unbundling of the standard of care is somewhat problematic. There's still a need to test for these infections. So we just need to figure out a way how we can do that better. The unbundling of so the PIVOT study partially addressed this issue by testing each participant for active hep B infection using a point of care test. But participants were still required to have that separate venous blood draw to test for all of the other infections. So this is the context where a multiplex point of care test, so that's a device that can detect for more than one test analyte simultaneously. This has potential cogency here. And multiplex point of care tests for infectious diseases are becoming available. They have good feasibility and acceptability among people, among patient groups, including people who inject drugs, but they are they have varying levels of accuracy, and very few have actually been considered approved for clinical use as yet. And so until we have reliable and approved multiplex bloodborne virus and STI sets point of care tests, there's probably going to need, so we're probably going to need to continue to have a venipuncture sample concurrently conducted concurrently to the point of care test. And this will probably remain until we have a multiplex. Another major challenge which has not yet been faced by services responsible for hep C care in the prisons is how to successfully integrate this hep C testing, point of care testing, into mainstream practice. So scale up of healthcare interventions requires consideration of not only just the point of care test, but also workforce capacity, the system structures, infrastructure requirements. What is the most suitable testing strategy? Is this going to be universal opt-out testing? Is it going to be risk-based testing? Is there potential for high-intensity testing campaigns? What does the model of care look like? Is it a one-stop shop model? Is it a two-tiered screening model? How are we going to sufficiently resource and support the development and sustainability of a strong health system? So we need education and training of a skilled workforce, and we need funding to continue to sustain these. And finally, scaling up of hep C testing and treatment alone will be insufficient to achieve hep C elimination in the prisons. And it's really important to consider the parallel scale up of prevention and harm reduction strategies, which really need to be emphasized in this space. So in conclusion, a one-stop shop intervention that integrates point of care testing was shown to enhance testing and treatment uptake. It markedly reduced time and increased efficiencies for treatment initiation, and it was thereby able to overcome some of the key barriers to treatment scale up in the prison sector. As I mentioned, these are important insights for policymakers, and they highlight that proactive simplification of hepatitis C care should be prioritized and should be implemented. And it's evident that this paper has already made substantial impact in the sector already globally. Hepatitis C elimination is within reach, but it requires significant and concerted efforts to continue to scale up hep C testing, treatment, and prevention in the prisons. And without this, it's going to be challenging to reach national and global hepatitis C elimination targets by 2030. So again, I'd like to thank the selection committee for this award and the opportunity to present this work today. And also thank you to my wonderful supervisors and all of the team for making all of this work a possibility.
So I think you'll all agree that was a really great, data-driven, elegant presentation. It was really terrific, well deserving of the award of the student prize this year. So
thanks, Tony.
I can award you that certificate.
Thank you.
And this paper is now open for questions. So please, if you're in the room, come to the microphone. And if you're online, we got any questions online yet? Not yet. The ever reliable Philip.
First of all, congratulations. That was really amazing, an amazing study. I guess I'm wondering what you would say about the prison authorities and whether they recognise, the population that they have there and the particular need and the opportunity of that setting to do the sort of work that this study is doing with that population.
Yeah, thanks for the question. So on the correctional authority side, it's fairly mixed. Actually, even on the healthcare side, it can be largely supportive, but still some poor attitudes or negative attitudes towards prioritizing Hep C testing and treatment in the prisons. On the correctional authority side, it's fairly, we know that it's fairly skewed towards slightly negative attitudes, so stigma and discrimination towards people who are living with hepatitis C, and in particular people in prison who are injecting drugs in prison. We actually, separately from this, as part of my thesis, was looking at actually exactly this. So looking at the health literacy of people in prison, officers, and all of the healthcare providers, looking at understanding the hepatitis C health literacy. So what are their knowledge, attitudes, and capabilities in terms of scaling up or supporting scale up of Hep C testing and treatment in the prisons? And we did find that there was some work to do with the correctional officers. Not to say that all correctional officers have negative attitudes, but they can be a barrier. And so it is an important component to be thinking about, is overcoming or changing those attitudes to try and get widespread support for testing and treatment. And just a little plug, we've just, on that study, on the education study, we were able to show that our preliminary findings, preliminary data show that education as a standalone intervention, so whole of prison education, does improve testing and treatment rates. So education does have a place, I guess, in the space.
So if I could continue on that line a little bit. So the nurse is absolutely pivotal to this model. So have you had any feedback from the nurses in the system rather than the research nurses about how they would, whether they've got the capacity to fit it into their other responsibilities and how this would be prioritized? And then I guess as an adjunct question to that, is there any, or have you thought about any health economic modeling that would then justify, putting more resources in to make those issues easier to address?
Yes, thanks for that question. So nursing capacity is in funding for substantial nursing to take on point of care testing as part of their remit it's hard. Nurses are generally very stretched in their existing roles, but they are more or less very supportive of point of care testing. So they want to do it. It's more a matter of how do they do it, and if they're going to take this on, who is going to take up the rest of their work. So Jason's program, which is that scale up of point of care testing across the country, is supporting, I guess has allowed for nurses to really take on this role or encouraged the health services or the health departments to invest in creating specific point of care testing nurse roles. This isn't the case yet across the country. It's hard to find, as I was saying, funding for those dedicated positions, but they are critical and they're doing phenomenal work. And then the second part was
whether you could back that position up with some health economic modeling around cost savings and that sort of thing.
Yes, we are actually just looking at that at the moment. Data aren't available, findings aren't available yet, but yes, we are looking at doing some cost effectiveness analysis.
And can I ask you a couple of methodological questions? Sure. So you decided not to randomize, and you said, and I can sort of understand why this would have been difficult to randomize, but would you like to just elucidate that a little bit? And secondly, the timing was right at the sort of beginning of the COVID shutdowns and stuff. And so do you think there was any impact of COVID on your results?
So methodologically, the prisons are extremely challenging settings to run interventional studies in. Having both the point of care testing program, or the one-stop shop, and the standard of care running at the same time to randomize who was coming in, it was just really, really, really tricky. So it just wasn't feasible, was one of the biggest, I guess, barriers to randomizing there. And then the second question was
Impact of
impact of
because
COVID.
it was
Yeah.
accelerating during the time of.
So because the study was conducted up in Kempsey, it wasn't in the middle of the city. There was still an outbreak up there and it was still impacted by COVID lockdowns. But because of the point of care testing or the having a machine, it's quite portable. And so our research nurse, our study nurse, Amanda, was actually able to adapt really quickly. She instead of being based out of her clinic, sometimes she was based out of her clinic, but she actually ended up going out to the pods. So rather than having people coming up to her, which would have been a bit challenging with, all of the movements, trying to minimize the movements that were happening in the prisons, she ended up going out and seeing people out there just next to their cells. There wasn't really a huge impact on the number of people being received into prison. So the receptions didn't drop a huge amount. So there wasn't ultimately a huge impact on the study, which was fortunate in a way.
Nothing online. Oh, here we go.
Thanks a lot, Yumi. Just incredible impacts as well. That was so great to see. My comment was just to pick up on integration because I'm kind of obsessed with health systems, I suppose. And I think that, in the countries where I work, I often hear, why are you so focused on refining a cascade of care for one disease? In antenatal care, we're talking about a screening program. I just wondered if I could probe a little bit more about how this work fits into perhaps a bigger screening program in the prison setting, knowing what we know that, cost effectiveness results, for example, depend very much on the level of integration. And sometimes that can be a positive and it can be a negative. So yeah, I just wanted to hear and whether you had any plans to do more work in that space. Thanks.
Yeah, so definitely it's kind of one of the points that I was touching on, which is that hepatitis C point of care testing as a standalone test actually unbundles all of the other testing that could potentially happen. And so it's really, strongly pointing towards the need for either integrated screening strategies, whether it is point of care testing or not, making sure that, you do see that, have that comprehensive suite of tests that are happening, whether it's venipuncture or point of care testing. But also if we had a multiplex for, bloodborne viruses and STIs that could all be done at the same time on a single visit, you can picture, you can theorize that it's going to be something that would work in the prisons.
Just to add to that, in terms of a comment, I think integration is really important, but we're still at that phase where we're trying to get the RNA prevalence down in the prison settings. That's 10%. You look at Hep B surface antigen, HIV, syphilis, they're all less than 1%. So I think we need to keep pushing on a targeted Hep C elimination sort of component and then do the integration once we get the RNA prevalence down significantly lower.
Thanks, Greg. Totally agree.
Okay, so if there's no more questions, I think we should all congratulate Yumi again on both a fantastic paper with great impact and an even better presentation.